Good afternoon, everybody. Thank you for joining us at the IMW meeting in Boston. We've just returned from a really exciting CAR T-cell meeting, and I'm very privileged to be joined by three of the experts in the field. And so if it's okay, Dr. Cohen, I'd like to start with you. Could you just summarize kind of where you feel we are in the CAR T-cell world in myeloma at the moment?
Absolutely. So CAR T cells in myeloma so far have primarily targeted a protein called BCMA, which is highly expressed on plasma cells, including malignant plasma cells. And there have now been a number of studies that have demonstrated in very refractory patients, median 7 to 8 prior lines, that BCMA-directed CAR T cells can induce objective response rates anywhere between 65 to almost 100%, even in these highly refractory patients, and that can include a substantial proportion of patients developing very deep responses, VGPRs, even MRD negative CRs. And so it really seems like this is a very active type of therapy for these patients, especially patients who really have very few other options, and really has generated a lot of excitement in the field. I think what's been more variable is the durability of response. And so some of the earlier trials, the median PFS may have been anywhere from 4 to 6 months. Some of the later trials, we're seeing longer PFS, anywhere from 12 to 15 months. But we're still seeing this continuous pattern of relapse, and we're not seeing that plateau that we're seeing in some of the trials of CAR T cells in lymphoma and leukemia. So that's probably one of the main challenges going forward for us.
Okay. So, Dr. Raje, when we first heard about this a couple of years ago, we thought it was the cure, okay? And now, as Adam's saying, we're getting relapses and so on. Do we know why these are happening?
Obviously, this is an area of great interest, and as you pointed out, Faith, we had a really nice discussion earlier this morning and talking about what the potential problems are with this. And before we get into this, I do want to address the cure issue. Remember, we treated very, very refractory patients. And to me, seeing the kinds of responses we are seeing in these very refractory patients is actually incredible. Who would have thought that after 8 and 9 lines of treatment, you're seeing a CR, which is an MRD negative CR, and you're seeing a remission duration even of a year. So it's a little bit about expectations. And I do think as we move into earlier lines of treatment, our hope is that we are going to get better. Having said that, understanding why folks are relapsing post-CAR T cells is absolutely critical. And the way we kind of framed it this morning was we put it into 3 different buckets just for simplicity. And it could be sort of T cell intrinsic factors, which may be contributing to why these cells don't persist or expand. It could be tumor intrinsic factors, which could actually cause the prevention of this expansion. And finally, in myeloma, we've always talked about the microenvironment, as you know, and there are a bunch of cytokines, there are a bunch of accessory cells in the microenvironment which could have an inhibitory effect on this. So although we don't have a lot of data to speak to this, the research is ongoing and we're studying each of these. And the one final thing I would like to remind the audience as well, myeloma is very different from leukemia and lymphoma from a biology standpoint. Up until today, we've always talked about continuous therapy and forever treatment for a disease like myeloma. And CAR T cells is a complete paradigm shift in a disease where we know is immune kind of driven with really bad T cell function to begin with. So for us to understand all of these factors is going to be critically important for the success of this strategy going forward.
Okay. Dr. Avigan, we were kind of talking after we talked about reasons why patients maybe hadn't responded or had relapsed, about how we might improve the therapy moving forward. Would you like to just expand on that a bit?
Sure. So I think this is a really exciting time, but also the field is maturing a bit. And as we've been discussing, there's a greater appreciation about what the challenges still are to perfect this therapy or to kind of create a more durable response, which I think is what we're all pursuing. And one sort of fundamental question that Noopur was just referring to is the setting that we treat patients. The question about whether moving to an earlier setting where the disease may be a little bit less difficult and resistant, there may be less sort of heterogeneity around it, would that be more susceptible to treatment? There are fundamental questions about that. It may be that this strategy doesn't work as well when there's no disease around to trigger it. So I think those are some of the questions that we're going to ask in a series of trials that are now going to be done earlier in the disease and asking that very sort of important question about whether we could change durability by going earlier. I think the other sort of pieces of this are understanding resistance may not be the same in each patient, or there may be certain categories of it, and they may then require different remedies. There was some discussion today about ways to improve the CAR, either by having more than one target at a time, dual targeting CARs, for instance, that Adam and others have talked about, or amplifying the activation of the CAR, the so-called armored CAR, by putting in certain cytokines, or by allowing PD-1, for instance, to be blocked as part of the CAR strategy. And I think there's going to be also integration with other approaches. There's a long history of using immune modulatory therapy in myeloma, and whether that may play into perpetuating response or preventing tolerance. And I think on our side, there's also been an interest in looking at vaccines as a way to amplify the native T cell response, and that may interact with some of these other strategies, whether they be BiTEs or CAR T cells. So I think there's a lot of tools that we now have, a growing but not perfect understanding of what the barriers are, and hopefully those things will all be integrated in a way that's effective.
No, that's brilliant. Thank you. So Adam, I was going to say, Davies just said about maybe putting other immune strategies and other chemotherapies. Most of the CARs that are out there at the moment are BCMA with a T cell kind of approach. Are we exploring any other approaches other than BCMA and the T cell?
So absolutely, and there are a number of other effector cells that could potentially be transduced with the CAR and also have efficacy and perhaps a different toxicity profile. So there are several preclinical studies looking at natural killer cells or natural killer T cells as the cell type that expresses the CAR, and potentially able to kill the myeloma in other ways and not be susceptible to some of the same suppressive effects that are occurring in T cells. And we saw some of that data presented here preclinically, and some of those are now getting into clinical trials. So I think that's another promising approach. Another approach that I think is being explored to try to overcome some of the T cell dysfunction that's inherent in the myeloma patients is to use allogeneic CARs from healthy donors. And so you basically get a healthy donor with healthy T cells and are able to, through gene editing technology, eliminate the endogenous T cell receptor to get rid of the risk of graft versus host disease, put in other markers, molecules that may allow the cells to persist despite lymphodepletion. And then you could have an off-the-shelf CAR product that can be given directly to the patient right at the time that they need it. And so I think this is a really promising avenue as well. It's being explored in leukemias and lymphomas, and trials are going to be starting in myeloma soon too, and we'll see if this is effective.
I can just add that there is an international effort right now that the Multiple Myeloma Research Foundation is helping to support about integrating some of these dual therapies, this specifically targeting combining a vaccine approach where we take patient-derived tumor and create hybridomas with their dendritic cells to create a broad immune response, and certain dual CAR T cell strategies that are being developed at Sloan Kettering and in the Netherlands. So there's been an effort to put those two pieces together just as an example of, I think, dual targeting.
Oh, that's fantastic. That's fantastic. One of the scares when this all started was side effects, okay? And I was really quite impressed this morning about how we seem to know much more about the management of these, and it seems to be standardized a little bit. Can you expand a bit on that for me, Noopur?
Absolutely. I think all of us were afraid of the toxicities because of what we've seen with the leukemia patient population, where CRS and neurotoxicity was pretty significant. Now, these are the two most important toxicities that we still encounter with patients who are undergoing CAR T cells, and CRS essentially stands for cytokine release syndrome, and what it really is when your T cell targets the tumor and by doing so destroys the tumor, and when it does that it releases a bunch of cytokines, and these cytokines can make you quite sick. And typically most patients will present with a fever, sometimes a low blood pressure, and they need to be supported through that. You saw this morning, we'd sort of looked at all of the clinical trials in the context of multiple myeloma, and we certainly have seen very manageable CRS. We have a way of grading this now, and we've all learned as a community as we've done more and more of these treatments. So we've standardized how we can recognize it fast. And in the old days, I think part of the concern was if we treated this too early, would we be abrogating the effect of these CAR T cells? With data and longer follow-up now, we believe that that's no longer true. And we do know that there are cytokines like the IL-6 cytokine, which does play a very significant role in the development of cytokine release syndrome. And we have a monoclonal antibody which can target this IL-6, and we use a drug called tocilizumab, and most of us now are very comfortable using that. So what you saw this morning was, the majority of patients will have a grade 1 or 2 CRS, very manageable. Very few, if any, have the higher grade toxicities, and that I do think is part of a learning curve on the treating physician's side as well. The second toxicity which we all worry about with CAR T cells is neurotoxicity, and I don't think we completely understand the exact underlying mechanism of why that happens, but these T cells can certainly cross the blood-brain barrier and can cause brain swelling, but we don't really see that so much. So we've been very fortunate in the myeloma space where we've seen 1 or 2 patients who've had very significant neurotoxicity. Most times it's a very subtle neurotoxicity, and the way to pick it up is to really talk to the patient and talk to the caregiver and look at very subtle sort of word finding difficulties, a little bit of confusion, and that's sort of your first sign of neurotoxicity. And again, us being able to recognize this early has allowed us to institute treatment early, and the treatment for that has typically been steroids. In the old days, we worried about giving steroids to people who are getting T cells, which have been trained to go after your tumor cells with the notion that you're going to suppress these T cells. With longer follow-up now, the doses of steroids that we use for this is not that high, and it does not seem to affect the efficacy of these CAR T cells. So I think recognizing neurotoxicity early and instituting treatment early has been good. The good news is, we've done, I believe now, close to, if you combine all clinical trials together, close to 300 patients with myeloma who've gotten a BCMA-directed CAR T cell, and we've been very, very fortunate where we've seen very little in the ways of toxicity, which is a good thing, really.
That's really encouraging. So just in closing, I'm going to work my way down the panel, so I'll give you a warning there. Adam, what patients should I be thinking about sending to a CAR T cell expert like yourself?
So I think right now, most of the trials have been done in the heavily refractory population, patients who have already seen a proteasome inhibitor, an IMiD, and a CD38 antibody. And that's likely where the initial approval, if it happens, is going to be available. So those are the patients I would think about, but I would encourage not to wait until the 8th line of therapy like some of the original trials, and that once patients have really failed all those classes of agents, that would be a reasonable time to think about sending the patient over. As David mentioned, ultimately we'll be doing trials earlier in less heavily pretreated patients, and those trials are underway now, and even potentially in the upfront or consolidation setting for high-risk patients. But those trials we don't have data for quite yet.
Yeah, I was going to ask David, do you think this is an approach for high-risk patients?
I think that that's a really important question that we don't know the answer to. I think this field has been blessed by, frankly, a group of patients that have been so dedicated to moving the field forward and being partners in that I believe that over the next number of years, we're going to be doing studies in some of these unique settings, including earlier on high-risk settings, and learning a bit more whether toxicity is any different for those group of patients or not, whether the effectiveness of this treatment is more prolonged or more durable, and all of that will sort of contribute to a judicious use of how we best approach treating patients with this very powerful modality.
And Noopur, everybody keeps telling me this is going to replace stem cell transplant. Do you think it is?
You know, I do think we should, with this kind of therapy, we should start at least thinking about it. And we're just about starting to do the early phase trials, so treatment in the earlier phase of the disease. And one thing to do is to consider doing a trial where we can replace an autologous transplant and see if this would be the modality. So that would be where I would consider using it specifically in the high-risk patient population. Can you replace an auto transplant with this? Because despite what we do in that very high-risk patient population, you know, we have done better than we used to, but we have a lot of work and we need to do a lot better in that patient population, but it would be a perfect place to test this. There is an ongoing trial as we speak, wherein for high-risk patients, we are doing it when they relapse within their first post their immediate transplant. So we haven't quite replaced the transplant, but the next step would be to replace that transplant once we see the safety with this.
Excellent. Thank you guys so much for spending some time with me and taking time out of your busy schedules. We'll bring that discussion to a close now, and I'd like to thank the audience for spending time with us at IMW in Boston. Thank you very much.